Hi guys, just doing a quick presentation on the tissue layers of the head and neck. Right, so we know you've done this before, but we'll just run over the quick layers of the neck for you. So superficially, surrounding everything is the superficial cervical fascia or the subcutaneous tissue. That's all in yellow here, and then further everything's compartmentalized by the deep cervical fascia.
If you press the full screen.
Yeah, where's that?
Top right.
Yeah. Right, okay. So the superficial cervical fascia is basically a layer of fatty connective tissue between the dermis of the skin and the investing layer of the deep cervical fascia. It just contains some cutaneous nerve, blood and lymph vessels, and some superficial lymph nodes. The other thing that it contains more markedly is the platysma muscle, which is just simply, you've gone over it before, but a broad thin muscle on the anterolateral aspect of the neck, which attaches superiorly to the mandible, going down to the lateral clavicle and superior pec major and deltoid. Then going on to the deep cervical fascia layers, the three functions of the deep cervical fascia layers are: one, for movement, so to provide slippery surfaces so the layers can slide over each other and allow you to move your neck. The other is just to contain the viscera in different compartments, and the third being that it just provides a passageway for neurovascular structures to enter and leave the head and neck. So you've got four different sections of the deep cervical fascia. You've got the investing layer. I'll just do this all very quickly, which basically is around the edge here, which contains your trapezius, sternocleidomastoid, and also your submandibular and parotid glands. Next, you've got your pretracheal layer, which is around here. That has two layers, the first being the muscular layer, which contains the infrahyoid muscles, and then the visceral layer containing the thyroid gland, esophagus, and trachea. What should also be noticed is the posterior superior aspect of this fascial layer is continuous with the buccopharyngeal fascia of the pharynx, which is clinically important. I'll tell you later why. Next off, you've just got the pre-vertebral layer, which surrounds the vertebrae and the deep muscles. And finally, the carotid sheath, which shares its borders anteriorly with the investing and pre-tracheal layer, and posteriorly with the prevertebral layer. And it just contains the carotid artery, the internal jugular vein, and the vagus nerve, as well as some sympathetic nerve fibers. So basically that's just summarised there what we've just been over, very simply. So going on to the clinical significance of all this, why it's clinically significant of the fascial layers is because infection, it can be a cause of a spread of infection or cancers or anything like that. So between the investing layer and the muscular part of the pretracheal layer, it will not spread past the manubrium, whereas if it's between the investing and visceral layer of the pretracheal layer, it can spread down into the thoracic cavity and anterior to the pericardium, which can cause obviously some further complications. And also, if pus behind the paravertebral layer can perforate into other fascial layers, which can include the retropharyngeal space, which can present with dysphagia or dysphonia, which is difficulty in speaking. The retropharyngeal space is this space here. We found it's labelled on this one as this space here, but actually we found that's actually called the danger space. It's commonly confused. The retropharyngeal space is actually so anteriorly bordered by the buccopharyngeal membrane of the pharynx, and posteriorly by this line going across here known as the alar fascia. And then the danger zone, which is very similar but commonly confused, is actually this one here, which is bordered anteriorly by the alar fascia and posteriorly by the prevertebral layer. Right, quickly going on to the superficial layers of the head. There's 5 layers: the skin, cutaneous fat, aponeurosis, loose connective tissue, and the periosteum, which handily the acronym is SCALP. The first 3 interact intimately and move together as one. I'll just go over those quickly on in the diagram. So first of all, you've got the skin there, which has hair follicles, sebaceous glands, and sweat glands. Then your subcutaneous layer there of tissue, which contains cutaneous nerves, etc. Then you've got the aponeurosis, which is like a sheath, a tough sheath, which the muscles of the head attach to, including the occipital frontalis, and together the muscles and the aponeurosis are known as the epicranius. Then deep to that, again, you've just got the loose connective tissue, which is like a spongy-like layer with holes which can be filled with fluid during infection or injury, which can be clinically significant, which I'll go on to tell you about. After that, you've just got the periosteum of the neurocranium. So clinically significant cuts to the aponeurosis of the scalp can be made worse due to the opposing contraction of muscles, including the occipiter frontalis. And the loose connective tissue layer that I was saying, the second one from the bottom, is known as the danger zone, as infection in these spaces can spread via emissary veins into the cranial cavity.
I'm going to take over. So we thought this was an important point. Does anyone know what the difference between emissary veins and the diploic veins are? Just generally, we thought that was an important point. So I'll show you a diagram in a second, but the emissary veins, they connect the extracranial venous system, so the veins outside the cranium, with the intracranial venous sinus, which I'll show you, whereas the diploic veins, they channel between the inner and the outer calvaria of the skull. Calvaria is the very hard, bony layers of the skull, and in between you have a more sort of a layer with lots of holes in, which I'll show you. So if we look at this diagram, so here is, let me see if I can grab this. Yeah, okay. So here you've got the scalp, and you've got here, that's a filling of like blood, so that on here is labelled as a dural sinus, so that connects to the outside of the scalp via the emissary vein, whereas the diploic veins are actually running through the inner part of the skull. So you see they go through these holes, which are actually called diploae here. Okay, so I'm going to talk a little bit about meninges. I know we've covered it, but I'll go into a bit of why it's clinically significant as well. So on this diagram, we've got the layers. So we've got periosteum, the actual bone of the skull, and then we've got Dura Mater, which is separated into a periosteal layer and a meningeal layer. You've got space underneath that called the subdural space. You've got the Arachnoid Mater, which, as we mentioned, have mentioned before, it's like a web appearance. Subarachnoid space beneath that, and the Pia Mater, which is a very thin layer directly adherent to the brain. So the Dura Mater's outermost part, fibroelastic, contains major blood vessels. As I've said, it has 2 layers, and its role is to surround and support the dural sinuses, those sinuses filled with blood that we saw. Arachnoid Mater, its function is to actually cushion the central nervous system, and to do that it's filled with cerebrospinal fluid. And just to mention a bit of terminology, leptomeninges refers to the Arachnoid Mater and the Pia Mater, simply just because they're thinner than the Dura Mater. The Pia Mater is firmly adheres to the brain, and it's thought to be impermeable to fluid, but it is pierced by blood vessels to the brain and spinal cord. Unfortunately, we don't have much time, but if anyone wants to ask any further questions, like on the clinical significance of these different layers, then we'd be happy to do that. So thanks very much.